Government issues. Clinical guidelines. For adult COVID-19 patients. Mild disease. Upper respiratory tract symptoms, and or fever, without shortness of breath or hypoxia. What to do? Home isolation and care. Physical distancing, hand hygiene. Monitor temperature and oxygen saturation. Seek immediate medical attention if difficulty in breathing. High-grade fever, severe cough, particularly if lasting for over 5 days. A low threshold to be kept for those with any of the high-risk features. Age greater than 60 years, cardiovascular disease, chronic lung/kidney/liver disease, obesity. Therapies based on low certainty of evidence. Ivermectin, 200 mcg/kg once a day for 3 days. Avoid in pregnant and lactating women. Or DAB-HCQ, 400 mg BD for 1 day FB 400 mg ERD for 4 days, unless contraindicated. Inhalational SNI, given via metered dose inhaler/dry powder inhaler at a dose of 800 mcg BD for 5 days, to be given if symptoms, fever and/or cough, are persistent beyond 5 days of disease onset. Moderate disease. Any one of 1. Respiratory rate greater than 24 per minute, breathlessness 2. SpO2, 90% to less than 93% on room air. What to do? Admit in ward. Give oxygen support. Target SpO2, 92 to 96%, 88 to 92% in patients with cough. Follow proning, sequential position changes every 2 hours. Anti-inflammatory or immunomodulatory therapy, INJ. Methylprednisolone 0.5 to 1 mg/kg in 2 divided doses, or unequivalent dose of dexamethasone, usually for a duration of 5 to 10 days. Patients may be initiated or switched to oral route if stable and/or improving. Moderate disease. What to do? Anticoagulation. Conventional dose prophylactic unfractionated heparin or low molecular weight heparin weight-based, for example, enoxaparin 0.5 mg/kg per day, SC. There should be no contraindication or high risk of bleeding. Monitoring. Clinical monitoring, work of breathing, hemodynamic instability, change in oxygen requirement. Serial CXR, HRCT chest to be done only if there is worsening. Lab monitoring. CRP and D-dimer 48 to 72 hourly, CBC, KFT, LFT 24 to 48 hourly, IL-6 levels to be done if deteriorating, subject to availability. After clinical improvement, discharge as per revised discharge criteria. Severe disease. Any one of 1. Respiratory rate greater than 30 per minute, breathlessness 2. SpO2 less than 90% on room air. What to do? Any one of. Admit in ECU. Respiratory support. Consider use of NIF, helmet or face mask interface depending on availability, in patients with increasing oxygen requirement, if work of breathing is low. Consider use of HFNC in patients with increasing oxygen requirement. Intubation should be prioritized in patients with high work of breathing/if NIF is not tolerated. Use conventional RDSNet protocol for ventilatory management. Severe disease. What to do? Greater than anti-inflammatory or immunomodulatory therapy. INJ methylprednisolone 1 to 2 mg/kg 4 in 2 divided doses, or unequivalent dose of dexamethasone, usually for a duration of 5 to 10 days. Greater than anticoagulation. Weight-based intermediate dose prophylactic unfractionated heparin or low molecular weight heparin, for example, enoxaparin 0.5 mg/kg per dose SCBD. There should be no contraindication or high risk of bleeding. Severe disease. What to do? Greater than supportive measures. Maintain volemia, if available. Use dynamic measures for assessing fluid responsiveness. If sepsis, septic shock, manage as per existing protocol and local antibiogram. Greater than monitoring. Serial CXR, HRCT chest to be done only if there is worsening. Lab monitoring. CRP and D-dimer 24-48 hourly, CBC, KFT, LFT daily, IL-6 to be done if deteriorating, subject to availability. After clinical improvement, discharge as per revised discharge criteria. When to consider using remdesivir. Greater than moderate to severe disease, requiring supplemental oxygen, and greater than no renal or hepatic dysfunction, EF less than 30 ml per minute/m2, AST/ALT greater than 5 times UL and not an absolute contradiction, and greater than who are within 10 days of onset of symptom, S. Recommended dose, 200 mg for on day 1F, B 100 mg for next 4 days. Not to be used in patients who are not on oxygen support or in home settings. When to consider tocilizumab, off-label, when all of the below criteria are met. Greater than presence of severe disease, preferably within 24 to 48 hours of onset of severe disease, ECU admission. Greater than significantly raised inflammatory markers, CRP and/or IL-6. Greater than not improving despite use of steroids. Greater than no active bacterial/fungal/tubercular infection. Recommended single dose, 4 to 6 mg/kg, 400 mg in 60 kg adult, in 100 ml NS over 1 hour. Convalescent plasma, off-label, only when following criteria are met. Greater than early moderate disease, preferably within 7 days of symptom onset, no use after 7 days. Greater than availability of high-titer donor plasma, signal to cutoff ratio, S/O, greater than 3.5 or equivalent depending on the test kit being used.